Hello, my dizzy-loving friends. My name is Rodney Amran, and today we are going to demystify the assessment of the dizzy patient. You can follow me on Twitter at Dr. Amran, and you can also look at my website for all the information and associated materials at highrisklowfrequency.com. The method that we're going to talk about today is called the triage titrate tests method, and it has been shown to be both reasonable to do at the bedside as well as accurate and reproducible. Now you might ask, why dizzy? Why assess the dizzy patient, and why is this such an important thing? One thing that has been shown is that stroke is one of the most common misdiagnosed diseases. It's one of the big three. It also leads to a considerable amount of misdiagnosis, and dizzy in particular leads to excessive tests like MRI, CT, excessive admissions in America to the total of more than $10 billion. The accurate way to approach the assessment of the dizzy patient is to start with the triage of the dizzy patient. When we are triaging the patient, we are looking at the dizzy plus. So dizzy plus is the way to rule out central causes. So dizzy plus chest pain leads us to acute coronary syndrome or a dissection. Dizzy plus shortness of breath may lead us to a pneumonia or a pulmonary embolism. Dizzy plus low sugar would suggest hypoglycemia. Dizzy plus high sugar could suggest diabetic ketoacidosis. Dizziness plus ataxia may point us in the direction of a central process or a vertebral artery dissection. Dizzy plus orthostasis might be vasovagal, it might be hypovolemia, but you have to be aware that sometimes carotid artery stenosis is a common mimic. And then dizzy plus exposure might lead us to the assessment of whether or not they were exposed to certain drugs that can mimic a central cause, like alcohol can even do that, or carbon monoxide. So if they have a headache, you'd be considering that. So dizzy plus is something to take away a lot of stroke mimics that are life-threatening or benign, but not in the direction of a central process. The next step is to do something called titrate. Titrate is a mnemonic that stands for timing, triggers, TI, and then TR, and targeted exam. So for timing, all we want to know is whether or not it's a short duration, in which it is less than 15 hours, which would suggest something called episodic, or if it's a long duration, which would suggest acute vestibular syndrome. Now, if it is episodic, which means that it is less than 15 hours, really, if it is actively present and hasn't been there for days, then you can subcategorize that into triggered, or spontaneous. Triggered or spontaneous can then be further broken down. Episodic plus triggered means that you are able to elicit the dizziness only when you do something to them. In that case, you would try to do a Dix-Hallpike to look for posterior canal BPPV, or you would do a supine roll to look for horizontal canal BPPV. If it's episodic and spontaneous, then that could point us in the direction of vasovagal, but you have to be careful because that can also, with specific types of infarcts, lead us to a stroke. So if they are a vasculopath and have a elevated ABCD squared score, then you might want to consider pursuing a central cause, especially if they have none of the typical finding on Dix-Hallpike or supine roll. Now, with the Dix-Hallpike and supine roll, what you're looking for is, with the posterior canal, an upbeat rotary nystagmus and nothing else. Anything other than that is abnormal. With the supine roll and the horizontal, you're looking for left or right beating nystagmus. Anything other than that is considered pathologic. Next, if we are looking at a longer term symptom, like something that's been going on for 15 hours and is present without movement, we can consider that a acute vestibular syndrome. And an acute vestibular syndrome can further be subdivided into spontaneous or post-exposure. So acute vestibular syndrome, which is AVS, plus post-exposure can be due to a head trauma, carbon monoxide, illicits like alcohol, anti-seizure medicines, and antibiotics like gentamicin. Some anti-seizure medicines like phenytoin can cause you to have an acute vestibular syndrome and mimic a stroke. But if they have an exposure of some kind, then that points us in the direction of a different cause. Now, if it is spontaneous and there isn't any of these exposures, then that leads us to something called AVS plus spontaneous, in which case you need to do the following. You need to perform a Hintz exam. And a Hintz exam is basically combining a few physical exam findings that physiologically are there before you can see the anatomy of the stroke. So before you actually have ischemia or infarct to the tissue, you're going to start to see these findings. And if you assess them individually, they might not give you a high enough likelihood ratio positive and negative, but if you assess them together and in series using a Bayesian approach, then that increases the sensitivity and specificity quite high. In fact, higher than MRIs in some study. For example, the head impulse test is the first part of Hintz. The second part is nystagmus. What that means is you have to have nystagmus that's one direction, left or right. If you don't, you are pointing towards a central cause. Next is test of skew, and then it's called Hintz plus, which means if there's any hearing loss, that points us in the central cause. So to break this down a little bit further, if you have AVS plus spontaneous, what you're looking for is a head impulse test, is whether or not they have a saccade. Now, if there is a saccade, then that points you into the peripheral. But if there is no saccade, which means that you don't really have what they call a vestibular ocular reflex, then that points you towards central. Furthermore, the next letter is N in Hintz, and that means that you must have unidirectional beating nystagmus. If there is no nystagmus, or if it is upgoing, downgoing, or to the left when you look to the left, or to the right when you look to the right, it is central. Only one direction beating nystagmus is peripheral. The next part of Hintz is called test of skew. Now, people have strabismus, and they have esotropia and exotropia. That doesn't mean that they have a central cause. The only time a test of skew is positive is if it's vertical, so if it's up or down. And lastly, we are looking at hearing loss. Hearing loss always points us to a central cause because of the rare but deadly AICA strokes, which affect the inner ear. And if you have that kind of stroke, oftentimes the MRI may be initially negative and then turn positive after a few days. So hearing loss makes us worry about a central cause. If you do this systematic approach, you will always be able to assess the dizzy patient in a timely and effective manner. I really hope this helped you to understand the dizziness mantra. After we are complete, then we order MRIs and we order CAT scans. Now, one last thing, a CT scan should never be ordered unless the patient is a trauma victim or they're on anticoagulation. It has very low yield in the assessment of the dizzy patient. And the MRI should be ordered whenever we are worried about a central cause, or we should consult. If you follow this mantra, then you will be able to assess the dizzy patient in a much more effective manner. I really hope this helps you. Have a good day.